Hello and welcome to part 1 for the cardiovascular system for clinical cases. Today we're going to be looking at some of the pathology and pathophysiology behind the cardiovascular system, including atherosclerosis, arterial and venous ulceration and how they differ from each other, cardiac tamponades and also pericardial effusions and how these may differ, essential and secondary hypertension, and peripheral vascular disease. So let's begin by having a look at atherosclerosis. So clinically, atherosclerosis essentially is the hardening of any artery by the buildup of these atheromatous plaques in the tunica intima or the endothelium. The tunica intima, of course, is the most inner layer of a blood vessel, and it is the layer that is affected most predominantly by atherosclerosis. Also be aware of arteriosclerosis, so this is more of an umbrella term where the artery walls harden, thicken, and become less elastic. But atherosclerosis is more specific in the respect you've got this atheromatous plaque in the tunica intima. Atherosclerosis is a disease which causes the arteries to narrow due to the buildup of plaque, and essentially the word atheroma means a fatty streak inside the arteries. Atherosclerosis is a disease that takes a long time to manifest, and therefore it doesn't present usually until later on in life, and there is, as a result, one of the risk factors is indeed age. It's also more prevalent in males, but also those who have abnormal vessel anatomy, diabetes, hypertension, lipid disorders, and also smoking and sedentary lifestyle can also contribute to the development of atherosclerosis. In terms of treatment, we could use medications to lower the cholesterol, such as statins. We could use medication to decrease clotting, such as aspirin. And we can also use medication to monitor blood pressure. But these are really prevention mechanisms, in other words, treating what's causing it. So in terms of prevention, really, we can eat a healthy diet, we can exercise, we can not smoke, we can maintain a normal weight, all what we'd class as a healthy lifestyle, really, all to prevent atherosclerosis. But healthy diet, I guess, is the particular one because it does stem from low-density lipoproteins. In terms of signs and symptoms, it is fairly asymptomatic, it builds up for decades, and it's only actually when it comes to a point where the artery may narrow so much that it impedes blood flow, actually then will it induce symptoms. In terms of the pathophysiology then, well, how do these plaques build up? What are they? Well, the endothelium, of course, the normal role is to protect the vessel wall and prevent blood from clotting. And if you have damage to the endothelium, this can occur in many different ways, from low-density lipoproteins, from the chemicals that are involved in smoking, or from having high blood pressure. Now, when the endothelium becomes damaged, low-density lipoproteins can then enter the damaged endothelial wall, and monocytes, which are freely flowing in the blood, which are precursors to macrophages, these follow the low-density lipoproteins into the endothelial wall and break them down by oxidation. So the macrophage, we terminate a macrophage now, but essentially this is just the outcome of what a monocyte is the precursor for. So the macrophage ingests so much cholesterol from the low-density lipoproteins that it dies. And when that macrophage dies, it deposits under the damaged endothelium. And as a result, we now refer to this as a foam cell. So a dead macrophage is a foam cell. Macrophages release cytokines when they die. And the problems with cytokines are that they attract more monocytes. And the cycle continues, and more foam cells build up because more monocytes are attracted. They ingest the cholesterol-filled low-density lipoproteins, and as a result they die and foam cells build up under the endothelial wall. If you've got more foam cells, this causes the development of a fatty streak, and the fatty streak is determined thrombogenic. In other words, blood is able to clot upon it, in contrast to your normal endothelium where blood is unable to clot there. So platelets then gather at the damaged endothelium, and they release platelet-derived growth factors, and this encourages smooth muscle to grow. Now, as you know, smooth muscle is normally within the tunica media. However, in this case, the platelet-derived growth factor encourages the smooth muscles to be drawn into the tunica intima. As a result, this growing smooth muscle secretes an extracellular matrix made up of collagen, proteoglycans, and elastin fibrous cells. These form a cap or a wall around the fatty streak, and therefore now we can term it a plaque, an atherosclerotic plaque. So smooth muscle in the wall also starts depositing calcium into the plaque, and this crystallizes and hardens, and this is what causes a hardening of the artery walls. So normally your low-density lipoproteins deposit calcium in the cell wall, but this is normally okay because it's removed by the helpful high-density lipoproteins. However, here, an accumulation of plaque, this interferes with high-density lipoproteins' ability to remove calcium, and therefore you end up with a build-up of calcium which is deposited by the low-density lipoproteins in the artery wall. When this crystallizes, it becomes hard, and the artery wall stiffens. Another complication that can occur is, well, if the fibrous cap rips, and this does happen spontaneously from time to time, it exposes the foam cells to the blood. A blood clot starts to form in the already slightly blocked artery, so it's already slightly narrowed, but this narrows it even further, causing it to become around 70% occluded at this point. And it causes downstream cellular injury and death. And this box at the bottom really just illustrates what it could cause with regards to aneurysms or angina and MI. If it blocks the coronary arteries or if it blocks the internal carotids, it could cause a stroke and cerebral atrophy, for example. And likewise with popliteal artery, it could cause peripheral ischemia or claudication or gangrene. So really it's important to be aware of the complications that could arise as a result of the occlusion of an artery and where the artery is. Do bear in mind, however, that atherosclerosis is of course a slow process. It builds up over a long period of time, and although this kind of summarises it all in one go, this is happening over a very long period of time, which is why it's normally developed in older age. So next we have arterial and venous ulceration. So remember, hypertension and atherosclerosis of the peripheral vessels leads to arterial disease associated with ischemic ulcers, and chronic venous insufficiency and the resulting venous hypertension cause venous ulcers. So ulceration due to vascular causes, it's usually multifactorial. It's usually several things that can cause it, but it's important to be aware of the difference between an arterial ulcer and a venous ulcer, and you can classify these by their typical signs, really. So an arterial ulcer is more common in men than female, in contrast to a venous ulcer, which is more common in women. Normally arterial ulcers develop in patients over 60, whereas venous ulcers develop in patients between 40 and 60 roughly. The risk factors for an arterial ulcer include smoking, hypertension, diabetes mellitus, and hyperlipidemia. On the other hand, the risks for venous ulceration are DVTs, thrombophilia, and varicose veins. Usually patients with a venous ulcer, 1/3 of these patients get a slight pain, but 70% of these venous ulcers are medial. Swelling is usually present with a venous ulcer, in contrast to an arterial ulcer, where normally there's no swelling present. Remember, there are several different types of ulcers, not just arterial and venous. So you could have, for example, a neuropathic ulcer, which may be associated with diabetes. It's important to investigate the ulcer properly, so take a clear history. This will help you determine whether it's arterial or venous. Do a clinical examination and do an ABPI. So an ABPI measures the ankle systolic pressure divided by the arm systolic pressure. If you're worried about a vessel being occluded, for example, you could do a CT angiogram to rule out, to determine which vessel it is that's affected. Please be aware of Virchow's triad. So this is a physiological system really that states why you may get thrombosis. In other words, it is derived from 3 factors: endothelial injury, abnormal blood flow, and hypocoagulability, all leading to this thrombotic state. Next we have cardiac tamponade, which is essentially a compression of the heart as a result of a buildup of fluid within the pericardium. The onset of a cardiac tamponade can be rapid, so from trauma for example, or it can be more gradual. So as you can imagine here, gradual causes may be kidney failure, cancers, pericarditis, but a more rapid cause could be a chest trauma, which is probably the more common origin of a cardiac tamponade. It can increase up to more than 2 litres of fluid within the pericardium, and as a result this can rapidly compress particularly the ventricles of the heart, and as a result this can affect the pumping mechanism. In terms of treatment, it's important to carry out a pericardiocentesis, in other words a drainage of that fluid, and remember your normal anatomy of the pericardium, i.e. your visceral serous layers, your parietal and your visceral layer. Be aware of those and be aware of where the fluid's building up in that potential space in between, where there's normally just a little bit of fluid to allow lubrication of the heart, but really here you're getting a larger build-up of fluid in between those parietal and visceral layers, causing compression of the heart. Like I said earlier, pericardial effusion is slightly different from a cardiac tamponade in respect it is a build-up of fluid in the pericardial space, but it doesn't impact on the function of the heart. It doesn't compress the vessels. Next we have 2 types of hypertension. So first of all, essential hypertension makes up around 95% of cases of hypertension, and essentially it's hypertension with no identifiable cause. There are believed to be several risk factors contributing to the risk of hypertension, including age, an overactive sympathetic nervous system or RAS, increased activity, or increased sodium retention, so this relates to the kidney function. And with regards to signs and symptoms of hypertension, usually it's not really very obvious, unless it's in a pretty severe state where they may be possibly having headaches, fatigue, or it may also have a negative impact on the brain, so on memory and mental function. It could also cause visual problems, chest pain, difficulty breathing, but again we're talking this is quite severe hypertension. And we can grade hypertension stages to 1 to 3. So in stage 1, really you're looking at the BP in surgery being above 140 systolic or above 90 diastolic, stage 2 above 160 systolic or 100 diastolic, and severe hypertension or stage 3 hypertension above 180 systolic or 110 diastolic, and these are really requiring immediate treatment. Please be aware stage 1, stage 2 hypertension to possibly do a home blood pressure monitoring or an ambulatory blood pressure monitoring for 24 hours, because they could have white coat hypertension, for example, where their blood pressure is simply raised because they're in clinic or surgery, and at home it may not be as increased. So in terms of secondary hypertension, this is where we can identify a cause, and this really is in around 5% of cases. With this, it's easy to think of this as an ABCDE approach. In other words, for example, do they have any of these conditions which could be causing the hypertension? Ones to be aware of are really renovascular hypertension, so this is normally caused by things such as fibromuscular dysplasia, atherosclerosis stenosis or diabetes. It could be as a result of an endocrine disorder, so for example, pheochromocytoma. This is a tumour secreting excessive amounts of epinephrine. This promotes vasoconstriction, and of course this will increase blood pressure. Also, you could have Cushing's syndrome, which is where you get excess glucocorticoids, resulting in hypertension. There are also adrenal disorders such as congenital adrenal hyperplasia, which can lead to excessive production of mineralocorticoids. Again, this can lead to hypertension. But also bear in mind any medications that your patient may be on, and if these can be causing the hypertension themselves. There are other conditions such as aortic cortication, so this is narrowing of the aorta. It's a congenital abnormality, but it can cause hypertension as well. Please be aware that it may be secondary hypertension, i.e. not essential hypertension without a cause, if the patient is younger, if they're under 40, or if the patient is resistant to any medication attempts you've already tried. This increases the likelihood that it's actually a secondary hypertension with an underlying cause. Also be aware of target organ damage, so in other words, if you have continued hypertension, it can cause problems elsewhere in the body. So for example, you could have left ventricular hypertrophy, you could have a thickening of the carotid intima of the blood vessel, and you could have hypertensive retinal changes. In other words, you could see that classic silver wiring when you look inside the eye of the retina. Lastly, for this video, we look at peripheral vascular disease, and this is essentially any narrowing of the arteries outside of the heart and skull. It's pretty much always caused by atherosclerosis, so it ties in quite nicely with this video, but it can also be a secondary cause by something such as a thromboembolism or inflammation. Usually coronary heart disease is a major cause of death in people with PVD of the legs, and actually the survival rate is not far in the respect that 30% of patients with PVD die within 5 years, and the further 70% actually are within the 15 years. In terms of risk factors for peripheral vascular disease, you're looking at hypertension, hyperlipidemia, diabetes and smoking, which all have a strong association. They're the 4 main risk factors, as they are with atherosclerosis, but also stress, obesity, being male and over the age of 50 are all as well have some level of association with peripheral vascular disease. In terms of clinical features, pain is the most prominent, particularly claudication, and remember claudication is that cramping pain in the leg that's induced by exercise but then relieved by rest. In terms of clinical features, you want to check blood, you want to do an ABPI, so this is an ankle brachial pressure index. In other words, it measures the occlusion of the arteries in the legs and also the artery in the arm, and you may want to do, as we discussed earlier, angiography to check which vessel may be affected. In terms of management, a really key management here is to stop smoking immediately, engage in exercise. So these are really supportive mechanisms here, and pain relief may be used if the pain is bad enough. So these are, like I say, conservative measurements, and these actually are active and work in around a third of patients. You can use medications, so statins to lower low-density lipoproteins, ACE inhibitors to treat the hypertension, and silestazol, which might relieve that claudication. You don't particularly need to be aware of these drugs. That's everything for this video. If you do have any questions or any feedback, please do let me know. It'll be greatly appreciated. Alright, and we'll see you next time. Thank you.